I was sitting in a crowded cafe last Tuesday watching a woman at the corner table. To anyone else, she looked like she was just waiting for her latte. But if you looked closer, you could see he was working. Her eyes weren't on her phone. They were triangulating the room. She knew exactly who had walked in behind her without turning around. She'd already noted that the barista's voice had dropped an octave when talking to the manager, and she'd mapped out 2 different ways to reach the fire exit without crossing the center of the floor. When her friend finally arrived and joked about her being a bit jumpy because she flinched at a clattering spoon, the woman just laughed it off. Her friend told her she thought too much and simply needed a vacation. That's when the disconnect became jarring. From the outside, she was just anxious. But inside, she was the chief of security for a bunker that was currently under high alert. She wasn't overthinking. She was working a double shift at a job she never applied for, with no lunch break, no salary, and a military-grade radar screaming in her ribcage. While her friend saw a quiet afternoon coffee, this woman was navigating a live minefield, waiting for the ground to shift. It's a peculiar state of being where the body refuses to believe the war is over. It's as if the past kept a spare set of keys to your nervous system and decided to move back in at 3 a.m. to rearrange the furniture with your worst memories. We use clean, clinical words for it, but the reality's much sweatier, much more exhausted, and far more invisible. It is the ministry of permanent alert, and for some, the doors never close.
And, to really understand the clinical reality of what is happening to that woman in the cafe,
right,
we have to look at how the medical establishment, completely misunderstands the state of permanent alert.
Yeah, they really do.
Especially in the United States. This invisible, unpaid surveillance job is just routinely misdiagnosed. I mean, let's look at the reality of a specific patient. We'll call her Elena.
Okay.
So Elena is sitting in this sterile, white-walled clinic in Seattle. And the sensory details of that room are actually crucial to understand.
Because of how her brain is processing them, right?
Exactly. To you or me, it's just a waiting room. But for Lena, there was this specific 60 hertz hum coming from the fluorescent lights.
Oh, wow.
Yeah, and she could smell the faint, sharp scent of institutional sanitizer. And out in the hallway, there was this one floorboard that creaked.
Just normal building noise.
But she knew exactly which nurse was walking on it.
Really, just from the creak?
Just from the weight distribution of the footstep, her brain had mapped it. And sitting across from her is a psychiatrist, and he's literally hovering his pen over a diagnostic checkbox for generalized anxiety disorder, or GAD.
Right, just a standard anxiety label.
Yeah. And for 3 whole years, Elena had been treated under this label of worry.
That feels so inadequate.
It's completely inadequate because what she was experiencing wasn't some vague floating fear of the future. It was a high-stakes 24/7 surveillance operation.
I really want to pause on that specific diagnosis because in the American clinical system, insurance codes demand neat, clean labels.
Right. They need a box to check.
Exactly. They require a classification that dictates the entire path of care. So the system looked at Elena, saw a woman who was visibly keyed up, and just labeled her with a simple chemical imbalance.
Generalized anxiety disorder.
Right. And because of that specific label, the treatments they prescribed entirely missed the mechanical reality of what was happening in her body.
Oh, please.
They told her to practice mindfulness. They told her to sit quietly, close her eyes, and just, focus on her breathing.
Right. But for someone whose nervous system is operating a military-grade radar, mindfulness feels like a profound insult.
Yeah, it has to.
I mean, asking her to just be in the moment, it's literally like asking a soldier trapped in an active foxhole to close their eyes and admire the petals on the wildflowers.
Wow. Yeah, it completely ignores the biological imperative to stay alive.
Her body fundamentally believed that this was not a safe moment to be mindful of.
Right.
And it wasn't until she finally sat down with a trauma-informed specialist that the entire narrative actually shifted.
What did that specialist do differently?
Well, first of all, he didn't just offer her a sedative or, hand her a cognitive worksheet on how to logically relativize her fears.
Okay.
He recognized the mechanics of her posture. He looked at her white-knuckled grip on her purse. He noticed the shallow cadence of her breathing.
Just really seeing the physical reality of it?
Yeah, the way her eyes kept darting to track the micro-movements in the room. And he acknowledged the sheer, crushing exhaustion of what she was doing.
Because it is exhausting. It's a full-time job.
He recognized that this was a body drafted into an endless war. The threat detection system was permanently jammed in the active position.
And that's what the previous doctors missed.
Completely. They missed that the true weight of her condition wasn't simply the fear itself. It was the profound, quiet shame of being completely unable to live in a world that she couldn't stop scanning for exits.
You know, if you're looking at this from the outside, you really have to wonder why highly trained medical professionals fail to see the difference.
Right.
Like, why does the medical establishment look at a highly traumatized, hypervigilant person and just call them anxious? What is the mechanical breakdown happening in that diagnostic room?
Well, it really stems from a fundamental misunderstanding of the neurobiological orientation of these two states.
Okay.
So, generalized anxiety disorder is fundamentally oriented toward the future. It's a cognitive process. It's the brain asking, what if?
Like, what if I fail this exam?
Exactly. Or what if the economy collapses and I lose my job? What if something bad happens to my family?
It's all projection.
Right. It relies on imagination and projection, but hypervigilance. Hypervigilance is entirely anchored in the present tense.
It's happening right now.
Now, it's a body-based physiological threat detection system. Hypervigilance does not say, what if things go wrong tomorrow?
What does it say?
It says, things are going wrong right this second. There is a predator in the room, and I have already deployed a biological crisis response team to deal with it.
Wow.
It is an ancestral software program designed purely for immediate survival.
So we are essentially talking about an imagination problem versus a surveillance reality.
Exactly.
The timeline is completely different.
And that specific distinction regarding the timeline and the origin of the state, it actually drove a massive historical shift in how clinical psychology classifies these disorders.
Right, with the DSM.
Yeah. So for decades, post-traumatic stress disorder was actually categorized under the umbrella of anxiety disorders in the diagnostic manuals.
Which makes sense based on how they were looking at it.
Sure. But when the committees were drafting the DSM-5, which, is the Diagnostic and Statistical Manual of Mental Disorders, the primary psychiatric text used in the U.S., they made a critical structural change. They officially removed PTSD from the anxiety disorders category.
Really? Where did they put it?
They placed it into an entirely new, separate grouping dedicated specifically to disorders associated with trauma and extreme stress.
Because they recognize that the origin of the state changes the nature of the condition entirely.
Exactly. The DSM-5 committees and also the committees for the global manual, the ICD-11, they recognize that trauma-based disorders are set apart by their etiology.
Their root cause.
Right. They derive explicitly from an externally experienced traumatic event or environment, not merely from an internal cognitive loop of worry.
It's not just in their head.
No. Hypervigilance is an adaptation to an environment that definitively proved itself to be dangerous. The nervous system learned a highly specific lesson about survival.
And it learned it a little too well.
Way too well.
I want to look at the mechanics of why standard treatments fail when that etiology is ignored.
Okay.
Because standard cognitive behavioral therapy often asks a patient to logically challenge their thoughts, right? Yeah. The therapist asks you to evaluate the evidence for your fear. But treating hypervigilance with cognitive logic is, well, it's like trying to fix a blaring fire alarm by updating the building's computer software. Right. Like you can sit at the terminal and type all the code you want. You can logically program the system to understand there is no fire. But the hardware itself, the physical optical sensors on the ceiling, they are screaming that there is smoke in the room.
Exactly.
The physical sensors are completely overriding the software.
The cognitive level is entirely bypassed. You literally cannot argue the body out of a survival state using logic.
It just doesn't work.
Oh. When you tell a hypervigilant person, look around this room, there is no physical danger, you need to challenge your irrational thoughts, the traumatized nervous system simply does not process that reassuring press release from the present moment.
It's not reading the news.
Right. It only references the archives of the past. And in those archives, the danger was absolute. And it was real.
So when the medical system slaps an anxiety label on this state and prescribes, deep breathing or thought records, it completely ignores the physical hardware.
It ignores the body.
Which really brings us to the devastating physiological toll this state extracts from the human body over time. Because if the fire alarm is ringing constantly, we have to ask what that electrical current is doing to the wiring of the building.
It's burning it out.
Yeah. This mislabeling is not just a psychological oversight, it is a biological hazard. It completely ignores what is happening under the skin.
Absolutely.
Look at the reality of Elias. So Elias lived on a quiet, incredibly normal suburban street in Ottawa. The sensory environment of his life was objectively safe.
Just a normal neighborhood.
Exactly. There were frosted windows, the quiet hum of a kitchen refrigerator. The silence of a 3 a.m. neighborhood where the absolute most dangerous thing should have been like a stray cat crossing the road.
Right.
Yet at 3 a.m. in the dead of that quiet night, his amygdala was firing with the exact same electrical intensity as a night raid in Kandahar.
Wow.
Because Elias was a Canadian military veteran. And for veterans operating under this level of hypervigilance, the transition back to civilian life is a profound lie told by the body.
Yes.
The government issues the paperwork saying you are home, your family tells you that you are safe, but the central nervous system completely rejects that data.
And to understand the physical destruction happening to Elias, we really have to map out the neurobiological engine that's driving this state.
Okay, let's get into the biology of it.
So the biological switch that gets flipped during combat relies heavily on the HPA axis.
That's the hypothalamic pituitary adrenal axis, right?
Exactly. It's this incredibly complex set of direct influences and feedback interactions among three components. You've got the hypothalamus in the brain, the pituitary gland sitting just below it, and the adrenal glands located right at the top of the kidneys.
Okay, so a three-part system.
Right. So when Elias was in combat, his brain perceived an immediate life-threatening danger. The hypothalamus released corticotropin-releasing hormone, or CRH.
Which acts as the first alarm.
And that signaled the pituitary gland to secrete adrenocorticotropic hormone, ACT.
Okay.
That hormone traveled straight through the bloodstream down to the adrenal glands, prompting them to just flood his entire system with cortisol and adrenaline.
The classic fight or flight response.
Exactly. This cascade increases your heart rate, elevates your blood pressure, and boosts energy supplies to allow for fighting or fleeing.
It is the ultimate biological overdrive. I mean, it literally shuts down digestion, it alters immune system responses, it suppresses the reproductive system, all to funnel every single ounce of energy toward immediate survival.
Right. But in a healthy nervous system, once the threat passes, a negative feedback loop tells the hypothalamus to stop producing CRH.
The all-clear signal.
Exactly. And the system returns to a baseline state. But for Elias, that negative feedback loop is broken.
It doesn't shut off.
The hyperactivation of the HPA axis doesn't shut off. The switch stays jammed in the on position. And over time, this chronic activation begins to physically erode the vessel. Yeah. When Elias is lying in bed at 3 a.m. in Ottawa, his heart is laboring under a constant toxic bath of cortisol.
It's like a biological engine redlining in a parked car.
Yes.
The transmission is in neutral, the car is completely stationary, but the engine is just screaming at 10,000 RPMs.
And I want to look closely at how that specific biological redlining translates to his daily physical health, because this isn't just about feeling stressed, you know?
Right. How does that cortisol bath actually destroy the hardware?
Well, the clinical data connecting chronic hyperactivation to physical disease is overwhelming.
What are they finding?
The constant presence of adrenaline and cortisol literally damages the endothelial cells that line the blood vessels.
Oh, wow. Actual physical damage to the vessel.
Yeah, this continuous pressure leads to micro tears in the arteries. And then the body tries to heal those tears by deploying cholesterol, which leads to rapid plaque buildup.
So it's directly causing heart issues.
Exactly. Doctors are directly linking this chronic state of hyperarousal to early onset cardiovascular strain, severe hypertension, and a compromised immune system that just remains in a constant state of low-grade inflammation.
Fine.
Yeah.
And you see the mechanics of this playing out in the most mundane civilian environments, too.
Oh, everywhere.
Like when Elias attempts a task as simple as visiting the local grocery store, the biological engine is entirely out of sync with the environment.
Right, a grocery store should be zero threat.
But he walks into the produce aisle, and his body registers profound, jagged vulnerability. His eyes are involuntarily tracking the hands of every single stranger reaching for an apple.
Assessing if they are holding a weapon.
Exactly. His chest physically tightens with phantom pressure. He is experiencing a slow-motion physiological collapse.
Yeah.
And the thing is, this is not a badge of military readiness or some testament to his bravery. It is a neurobiological debt that the body is forced to pay, and it is a debt that no amount of metals can erase.
And to clinically categorize what Elias is experiencing in that grocery store, we look at the DSM-5's criteria for the arousal and reactivity cluster of PTSD symptoms.
Okay, the arousal cluster.
Yeah, this cluster specifically maps the physical manifestations of this altered baseline, so it includes hypervigilance, obviously.
Right.
An exaggerated startle response, reckless or self-destructive behavior, profound concentration problems, and severe sleep disturbances.
The sleep part is huge, isn't it?
Oh, the sleep architecture is particularly critical. When the body believes it is constantly under threat, It simply will not allow the brain to enter deep restorative REM sleep.
Because it's not safe to sleep deeply.
Exactly. Recent clinical research indicates that sleep disruptions, particularly trauma-related nightmares, are so foundational to the disorder that some trauma experts argue that if a clinician could only ask a single screening question for PTSD, have there been significant changes in your sleep architecture since the event?
Oh. If the Ministry of Permanent Alert refuses to close its doors, the security guards are never legally permitted to sleep.
Right.
The biological guards just remain at their posts until they collapse.
And clinical researchers categorize how the nervous system attempts to manage this overwhelming physiological flood by looking at emotional regulation spectrums.
Okay, how does that spectrum work?
Well, on one end of the spectrum is what we call overmodulation. This presents as emotional numbing, severe detachment, and dissociation.
So kind of shutting down completely.
Exactly. The brain is attempting to protect the organism from the sheer voltage of the trauma by forcefully severing the psychological connection to the physical body.
Like blowing a fuse to save the house.
Exactly. But on the exact opposite end of the spectrum, which is where Elias is operating, you have undermodulation. Undermodulation is pure, unfiltered hyperarousal. The emotional states and the physical sensations are completely uncontained.
Just wide open.
Wide open. And when a human being is stuck in a chronic state of undermodulation, the physiological wear and tear is immense.
Imagine.
The brain's architecture is continually soaked in stress hormones, and these hormones actively inhibit the hippocampus from processing memories correctly, and they actively prevent the prefrontal cortex from regulating emotional responses.
You know, the ultimate tragedy here really is the biological paradox of it all. Well, the brain creates this reality of constant threat in a desperate, deeply loyal attempt to keep the organism alive.
All right.
The amygdala remembers the danger of the war zone and essentially vows, I will never let you be caught off guard again. I will keep you safe.
Yeah, it's trying to help.
But in its relentless, unyielding attempt to save the person's life, the survival mechanism actively destroys the physical heart.
The survival mechanism becomes the very thing that degrades the organism. It's tragic.
Yes.
And while Elias's hypervigilance was forged in a literal physical combat zone, we really have to look at how modern society has engineered entirely different types of occupational war zones.
Absolutely. The civilian environments.
Yes. These are civilian environments where this exact physiological trauma response, this severe undermodulation we just talked about, is not only expected, but is actively relied upon by the institutions themselves to keep failing systems operational.
Because if the body adapts to survive a literal war zone, we really have to ask what happens when society designs a civilian workplace that mimics those exact same high-stakes life-or-death conditions.
Right. Look at the modern healthcare system.
Exactly. Consider the reality of a nurse named Sarah. So Sarah works in the United Kingdom under the National Health Service. She operates in a London A&E ward.
A massively high-pressure environment.
Incredibly. And the sensory anchors of her daily life are just relentless.
Yeah.
You've got the specific, jagged hum of failing respiratory machines,
Right.
the sharp smell of medical-grade antiseptic mixed with bodily fluids, the chaotic, overlapping alarms of triage monitors.
It's a sensory nightmare.
And over a decade of nursing, Sarah's brain has learned to decode every single frequency in that room. In the severely under-resourced environment of the NHS, her hypervigilance is not viewed by her management as a clinical symptom of trauma. It is highly praised. They call it her clinical intuition. They applaud the fact that she has developed a sixth sense that allows her to hear a patient's breathing pattern change from 3 cubicles away through a closed curtain.
But that institutional praise completely masks the reality that her intuition is actually a predatory gift.
Predatory how?
It preys entirely on her central nervous system.
Oh, yeah. Just consider what her mandatory 15-minute break actually looks like. She retreats to this windowless staff room. She sits in a plastic chair. Her cup of tea sits on the table, completely untouched.
Because she can't relax.
Exactly. Her hands are physically vibrating with residual adrenaline. She feels a profound, jagged sense of powerlessness. The healthcare system she works for is structurally failing, right? It's patching over massive cracks of government underfunding and severe staffing shortages by relying on her central nervous system to function as a human radar.
Yeah, they use her as the patch.
In this context, this highly adaptive state of hypervigilance is just an unsustainable fast track to complete biological burnout.
Yes.
She is neurologically overextended. She knows on a cellular level that if she actually allows her guard to drop so she can rest, the crushing psychological weight of the trauma she witnesses every single shift will finally catch up to her.
So she just can't stop.
Her brain's safety mechanism keeps her moving at a frantic pace so that she never has to actually feel how unsafe her environment is.
And you know what Sarah is experiencing in that windowless room is actually heavily documented in recent clinical literature.
Under what terms?
Under the specific concepts of secondary traumatic stress, or STS, and moral distress.
STS.
Secondary traumatic stress is defined as the emotional duress that results when an individual hears about or witnesses the firsthand trauma experiences of another person.
So it's trauma by proximity.
Exactly. And the physiological presentation mimics primary PTSD almost exactly. To understand the scale of this, we can look at a highly illuminating cross-sectional study conducted on emergency nurses in Ireland.
What did they find?
The researchers utilized validated psychometric instruments, like the secondary traumatic stress scale, to measure the prevalence. And the data they uncovered was frankly staggering. They found that 64% of the emergency nurses surveyed met the clinical criteria for secondary traumatic stress.
64%. I really want to make sure you listening understand the gravity of that statistic.
Yeah.
64% means that well over half of the emergency ward is operating in an active trauma state while trying to save lives.
It is not just a mild state of stress. The study noted that these nurses fulfilled all 3 core diagnostic criteria required for a full PTSD diagnosis.
All 3.
They exhibited intrusion symptoms, such as unwanted memories and nightmares about patient cases. They had avoidance symptoms, such as actively trying to avoid thoughts, feelings, or conversations associated with the trauma.
Right.
And severe arousal symptoms, exactly like the hypervigilance Sarah exhibits. Furthermore, the breakdown of who was most affected reveals a really critical variable.
Who was hit hardest?
The highest proportion of STS, a staggering 82%, existed specifically in the staff nurses.
The frontline workers.
Yes, the individuals continuously stationed at the bedside, manually managing the chronic overcrowding, the aggressive patients, and the direct emotional weight of the suffering, as opposed to management or advanced practitioners who operate with, different duties or physical buffers.
I have to push back a little on how society frames this entire concept, because we see this dynamic everywhere, not just in nursing.
Sure.
We constantly celebrate the employee who is highly adaptable. We praise the manager who has great intuition in a corporate crisis. We reward the person who anticipates every single catastrophic problem before it happens.
Right, the superstars.
But if we label this as trauma, aren't we just pathologizing basic competence? Like, where is the line between being exceptionally good at a high-stress job and being actively traumatized by it?
The line is really drawn at the biological cost and the inability to turn the system off.
Okay.
Competence allows you to solve a problem and then return to baseline. Trauma alters the baseline permanently.
That's a huge distinction.
When an institution relies on an employee's hypervigilance, they are relying on a nervous system that literally cannot power down. We are applauding a survival response.
Oh.
And that Irish study highlighted this biological cost by examining the coping mechanisms these nurses employed. The researchers found a statistically significant link between nurses suffering from STS and the use of alcohol to alleviate work-related stress.
Self-medicating.
Exactly. This data wasn't necessarily indicating full-blown addiction across the board, but it demonstrated a clear, desperate reliance on a chemical depressant to forcefully calm an overactive, burning nervous system.
To turn off the radar.
Right.
Yeah.
It proves that the competence is destroying the host.
It highlights that we are giving institutional awards to a nervous system that is actively collapsing. We are using their trauma as the glue to hold broken systems together.
Exactly. Which highlights a desperate need for organizational systemic interventions.
Because you can't just yoga your way out of this.
No. We cannot just offer these nurses a module on individual resilience training or a corporate mindfulness app and expect them to heal. The physical environment itself is traumatogenic. It actively generates trauma.
So what's the fix?
To address this, institutions require systemic support. Mandatory rest breaks that are culturally enforced, robust psychological debriefing protocols following critical incidents, and fundamentally better staffing ratios to reduce the profound moral distress of knowing what care a patient needs but being physically unable to provide it.
So, if this state of permanent alert is so pervasive, if we see it in childhood homes, in combat veterans like Elias, and in civilian emergency rooms with Sarah, how does the medical and legal establishment actually categorize it? Because if you are a patient seeking help, what a doctor writes on their clipboard dictates your entire path of care. It dictates what insurance will cover and what therapies you actually have access to.
This brings us to a deep, ongoing fracture in modern psychiatry regarding how to define trauma in the first place.
Okay.
Currently, there is a fundamental split between the two major diagnostic manuals used globally. You have the DSM-5, the Diagnostic and Statistical Manual published by the American Psychiatric Association, which is heavily utilized in the U.S.
Right, the American standard.
And then you have the ICD-11, the International Classification of Diseases, which is published and maintained globally by the World Health Organization.
And the global standard.
Yeah. And when both of these committees realized that the definition of PTSD needed updating from previous iterations, they took completely opposite philosophical approaches to a core problem known as criterion creep.
I want to make sure I understand criterion creep. Is that the fear that the medical establishment was basically diagnosing normal human suffering or everyday stress as a psychiatric disorder?
The committees were concerned that if the definition of trauma was too broad, the diagnosis of PTSD would lose its clinical utility.
Like if everyone has PTSD, no one does.
Right. It would be applied to ordinary life stressors like divorces or job losses rather than profound life-altering traumatic events.
Okay, sense.
But how the two manuals actually solved this problem created a massive divergence in patient care. The DSM-5 decided to expand the symptoms heavily while trying to tightly define the A criterion, the actual traumatic event.
So they made the list of symptoms longer.
They created a massive, highly complex list of 20 potential criteria spread across 4 distinct symptom clusters.
20 criteria.
Yeah. They added entirely new symptoms, such as reckless or self-destructive behavior, noting that this hyperarousal is highly predictive of externalizing behaviors and rule violations.
They also added an entirely new cluster regarding cognition, right?
They added a cluster called negative alterations in cognition and mood, or NACM.
NACM, what does that include?
This cluster includes persistent negative beliefs about oneself or the world, distorted blame directed at oneself or others regarding the cause of the trauma, and a pervasive inability to experience positive emotions.
Just a complete darkening of their worldview.
Exactly. The DSM-5 even added a dissociative subtype for individuals who meet the criteria for PTSD, but also experience depersonalization or derealization.
So it became a very broad net.
It became a highly complex, multi-layered diagnostic checklist that attempts to cover every possible manifestation of trauma under one large umbrella.
Okay, so the American manual built a massive umbrella. How did the global manual, the ICD-11, approach it?
The ICD-11 took the exact opposite approach. They prioritized parsimony and clinical utility. They believed the DSM's approach was just too cumbersome for daily clinical practice, especially on a global scale.
Well, they shrank it.
They simplified standard PTSD down to just its core, unique symptoms, re-experiencing the trauma in the present, deliberate avoidance of reminders, and a persistent sense of current threat.
That is much simpler.
However, and this is the massive structural shift, the ICD-11 recognized that standard PTSD did not adequately describe patients who had endured chronic inescapable trauma. So they introduced an entirely new, distinct, and highly debated diagnosis.
Complex post-traumatic stress disorder.
Yes, CPTSD.
For anyone navigating this system, CPTSD really feels like the missing puzzle piece. It explains the reality of people who feel that traditional PTSD, which is often framed around a single event like a car accident, entirely fails to capture the architecture of their mind.
Right, it's not about a single event.
So how does the ICD-11 actually define complex PTSD?
CPTSD is explicitly designed to capture the reality of prolonged, repetitive, and inescapable trauma. We are talking about environments where the victim has absolutely no viable means of escape.
What?
This includes severe child abuse, prolonged domestic violence, captivity, human trafficking, or polyvictimization.
Polyvictimization meaning multiple types over time.
Yes, the experience of multiple different forms of trauma over a developmental lifespan. And to meet the clinical criteria for CPTSD in the ICD-11, a patient must meet all the core criteria for standard PTSD, but they must also exhibit severe, pervasive disturbances in self-organization.
Okay, what do disturbances in self-organization actually look like in the physical and emotional reality of a patient?
The ICD-11 maps these disturbances across 3 distinct spheres. First is severe affective dysregulation. This means the patient has extreme difficulty managing their emotional responses. It can present as explosive emotional reactivity to minor stressors, or conversely, profound, impenetrable emotional numbing.
So either totally overwhelmed or completely shut down.
Exactly. Second is a persistent, deeply negative self-concept.
Like low self-esteem.
It goes way beyond low self-esteem. It is a deep, unshakable feeling of core worthlessness, chronic shame, or guilt. The individual fundamentally believes they are permanently ruined or defective.
Breaking. And the third?
Third is severe difficulties in sustaining relationships and feeling closeness with others. The interpersonal world is viewed as inherently dangerous.
So the global medical community recognized that chronic trauma fundamentally reorganizes the human personality, and they give it a specific name.
Right.
But what happens to a patient in the United States who have this complex trauma architecture, but is being evaluated by a doctor strictly using the DSM-5, which doesn't explicitly recognize CPTSD as a distinct diagnosis?
This is where the diagnostic maze becomes highly dangerous, because the DSM-5 folds some of these complex symptoms into standard PTSD or just leaves them unaddressed. The symptoms of CPTSD are frequently scattered across the manual and misattributed to entirely different, unrelated disorders.
Oh, that sounds like a disaster.
Just look at how traumatized youth are treated, particularly those in the foster care or juvenile justice systems. They are routinely, systematically misdiagnosed with attention deficit hyperactivity disorder, or ADHD.
Wait, ADHD. How?
Because the clinician observes a child who cannot sit still in a chair, who is constantly looking out the window, who is easily distracted. The clinician labels it ADHD hyperactivity.
But it's actually hypervigilance.
Exactly. The child's trauma-induced hypervigilance demands that they constantly scan the room for physical threats. They aren't suffering from an attention deficit. They are paying intensely close attention to survival.
Oh.
Furthermore, their trauma-induced avoidance, like refusing to engage with adults who remind them of abusers, is clinically mistaken for oppositional defiant disorder.
They are literally being punished and medicated for operating a survival mechanism that kept them alive.
Yes.
And I imagine the misdiagnosis cascade is just as devastating for adults.
It is arguably more stigmatizing in adults. Adult CPTSD is incredibly frequently misdiagnosed as borderline personality disorder, or BPD.
Okay, why BPD?
To an untrained clinician, the superficial presentation can look similar. Both conditions feature severe emotional dysregulation and intense relationship difficulties. But the underlying mechanics and motivations are entirely different.
So?
Borderline personality disorder is fundamentally characterized by a frantic, consuming fear of abandonment and a highly unstable self-image that fluctuates rapidly.
Right.
Complex PTSD, however, is characterized by relationship avoidance. The CPTSD patient pushes people away specifically to stay safe from anticipated harm, and their self-image isn't unstable. It is incredibly stable, but it is entirely permanently negative.
To put a mechanistic analogy to this diagnostic failure, treating CPTSD as a personality disorder is like looking at a patient with a severe autoimmune disease and diagnosing them with a bacterial infection. The clinician sees the inflammation, assumes an external invader, and prescribes massive doses of antibiotics. But the antibiotics do nothing because there is no bacteria. The body's own hyperactive defense system is attacking the host. By misdiagnosing the root cause, the clinician doesn't just fail to heal the patient, they often prescribe treatments, like highly punitive behavioral contracts, sometimes used in BPD treatment, that actively traumatize the patient further. They attack the camouflage, rather than understanding why the patient had to build the camouflage in the first place.
That differential diagnosis is so crucial. When a trauma survivor is led down a treatment path designed for a personality disorder, it completely invalidates the traumatic etiology of their symptoms.
It changes the whole narrative of their life.
Because it tells the patient, you are fundamentally defective, rather than you adapted brilliantly to an impossible environment, but those adaptations are now hurting you.
Which brings us perfectly back from the clinical definitions to the highly specific, daily, lived reality of the individual.
Right, let's look at the day-to-day.
What does it actually cost to operate a brain that functions as a full-time, unsalaried crisis management team? Let's talk about the logistics of survival. We talked about Elaine in the clinic, Elias in the grocery store, and Sarah in the hospital ward. But let's look at the invisible mental load of simply navigating an ordinary Tuesday.
Oh, the sensory exhaustion of carrying this mental load is immense, and it infiltrates every single minor interaction.
Imagine a hypervigilant person preparing for a simple, casual coffee date with a friend.
Okay.
If you look at an untraumatized nervous system, a normal person considers what they want to drink or what topic they want to discuss. The hypervigilant brain is executing a full-scale tactical assessment.
Long before they even arrive.
Exactly. Before they even sit down, they are analyzing the escape routes from the cafe. They are assessing the ambient lighting. Is the glare too bright? Will it trigger a migraine? Will it obscure their vision of the door?
They're mapping the whole room.
They are creating complex seating charts in their head to ensure they can secure a chair where their back is pressed firmly against a solid wall, granting them a full visual sweep of the entrance.
And you know, the surveillance doesn't stop once they're actually seated. The interpersonal processing is just as taxing.
Totally. During the conversation, their brain is automatically reading the microscopic shifts in their friend's vocal cadence.
Right.
They analyze a sudden 3.5-second silence in the dialogue, not as a natural pause, but as a potential imminent sign of conflict or rejection.
They're bracing for impact.
They're constantly measuring the distance between themselves and the nearest exit, calculating the trajectory of the barista walking behind them holding hot liquid. They're doing the threat assessment of an entire highly trained security detail while trying to sip a cappuccino, maintain eye contact, and smile as if nothing is happening.
And this exhaustive internal reality requires us to deeply deconstruct a highly pervasive myth in modern self-help culture.
Which myth is that?
Society is constantly bombarded with the mandate that we must step out of our comfort zones.
Right. The whole growth only happens outside your comfort zone thing.
Yes. We are told by motivational speakers and corporate wellness seminars that growth only occurs when we deliberately push our boundaries, when we embrace the unpredictable, and when we force ourselves to be uncomfortable.
That philosophy is catastrophically dangerous for someone operating with complex trauma or severe hypervigilance.
It is entirely counterproductive.
Why?
Because for a traumatized individual, their comfort zone is not a place of laziness, stagnation, or complacency. It is the absolute fragile edge of the only perimeter where their physical body does not actively believe it is going to die.
Oh, it's a perimeter of safety.
Yes. The comfort zone is a carefully constructed, highly rigid neurological baseline that requires massive amounts of daily energy just to maintain.
So pushing a highly traumatized person to just relax, to be spontaneous, or to step out of their comfort zone is not encouraging psychological growth. It is like demanding that a burned-out, sparking fuse box absorb a direct lightning strike to prove its capacity.
Right.
The electrical capacity of their nervous system is already entirely maxed out, just maintaining baseline survival while drinking that coffee. When society forces them into highly unpredictable situations or shames them for needing rigid routines, we aren't building their resilience. We are forcefully triggering a massive physiological threat response that drives them deeper into exhaustion.
And this misunderstanding frequently leads to what clinicians observe as the collapse of the functional facade.
The functional facade, like high-functioning anxiety.
Exactly. Hypervigilance is a highly deceptive state because it often fabricates individuals who appear incredibly, almost supernaturally, adapted to societal demands.
Right.
These are the people who can instantly read the emotional temperature of a room the second they walk in. They proactively smooth over interpersonal conflicts before the friction even occurs.
The peacemakers.
They anticipate the needs of their managers, their spouses, and their friends. And crucially, they never, ever complain about the workload. To the outside world, they are the ideal employee, the perfect, low-maintenance friend, the strong one in the family.
But the internal architecture holding that persona together is incredibly brittle.
Completely brittle.
This isn't living.
Yeah.
It is using both hands to hold the door shut against a Category 5 hurricane. They are burning every single ounce of their cognitive ATP and their physical energy to keep the perceived threat at bay.
Right.
They're managing everyone else's emotional state so that no one becomes unpredictable or dangerous. And when the inevitable biological bankruptcy occurs, when the adrenal glands finally fatigue, when the body says, I literally cannot sustain this heart rate anymore, and the person collapses into profound burnout or severe depression, society is always shocked. The people around them say, but she seems so strong. He was always so capable. I never saw this coming.
And society's shocked reaction reveals our collective systemic blind spots regarding trauma and mental health. We consistently mistake a highly calibrated, desperate trauma response for genuine competence and stability. We actively, monetarily reward the exact biological mechanism that is destroying the individual from the inside. We praise the hypercompetence and the meticulous perfectionism that actually stems from a terrifying fear of making a mistake and being punished. We praise the boundaryless giving and the constant availability that actually stems from a deep, complex fear of abandonment or rejection. We refuse to see the actual cost of this unpaid labor until the biological bill finally comes due in the form of severe autoimmune illness, cardiovascular events, or a complete psychological breakdown.
It is the ultimate tragedy of the functional trauma survivor. Society fundamentally loves and relies on people who anticipate everything and cause zero friction. We feed off their hypervigilance because it makes our own lives easier, smoother, and more profitable, completely oblivious to the fact that their internal dashboard is flashing critical red warnings 24 hours a day.
Well, if we look at the clinical reality of what it takes to actually heal from this state, it is vital to understand that recovery is not about a sudden cognitive realization.
You can't just talk yourself out of it.
No, you cannot simply realize you are safe and flip a switch to turn the radar off. As we established, you cannot argue with the physical body.
Right.
The nervous system does not read the press releases of your current safe reality. It only references the terrifying archives of the past. To officially resign from the unpaid job of hypervigilance requires a fundamental, prolonged neurological retraining of the HPA axis and the amygdala.
It is a slow, painstaking dismantling. It is the reality of healing, not as a sudden, glorious cinematic awakening, but as a slow, millimeter by millimeter return of the spare keys to your own nervous system. It is the grueling work of teaching the body in tiny, controlled increments that the war is actually over. It is allowing the military-grade radar to power down for 60 seconds, then 5 minutes, then 10 minutes, and proving to the biology that the world did not end. It is the quiet, profound, and deeply hard-won image of a person finally being able to sit in a room, hear a door open, and for the first time, not look for the exit.